I am going to pass the virtual microphone to the first team, and the presentation is Personal Health Records, Contrasting Views of Rural Patients and Providers. Take it away.
Good morning. Thank you. I'm Mindy Smith and very pleased to be here. And we'll be starting our talk now. So the first slide is show team members, and the team members represent a diverse group of UBC researchers, clinicians, patient partners, of whom I am one, a technical partner, and ministry decision maker. Electronic health records are used by providers to capture and sometimes share patient information, and they have been shown to enhance care, primarily through reminders, tracking systems, flagging potential medication errors, and creating practice registries. However, the patient voice has largely been absent from care documentation and participation. The use of personal health records is one way to engage patients in managing their own health, particularly important for patients in rural areas who have lower life expectancy, poorer mental health, and higher rates of unhealthy behavior and obesity. The ideal personal health record is an electronic tool for patients to access, manage, and share health information in a private, secure, and confidential environment. Data can be entered through multiple sources, which is shown on the left-hand side of the screen, such as wearable devices. The patient, however, is the owner or manager of the data repository and can choose to share information with others. There's also bilateral communication, which occurs between patients and providers, as shown on the right-hand side of the slide, and for recording images and laboratory reports or other data. There are many types of data that can be stored on a PHR. Typical things like clinical data, allergies, medications, but also personal reflections. And one of the many benefits of a PHR is that data can come from multiple providers. Personal health records have been shown to decrease emergency room visits and preventable hospital stays in patients with chronic disease. They've also been associated with increased patient satisfaction and disease control in patients with diabetes, asthma, and hypertension. However, uptake thus far has been pretty slow. The impetus for this study was the planned implementation of a PHR in primary care networks in several rural communities in British Columbia. A primary care network is a healthcare team providing primary care services to a local population. The purpose of our study then was to understand rural patients and providers' perspectives of PHRs before their implementation within the PCNs. This is phase one of a two-phase study to implement a PHR and to understand patients as partners in a rural primary healthcare context. We used qualitative descriptive design. Our sample included providers across the primary care networks and patients living in the region who were part of a patient advisory committee. Patients, one group, and 4 groups of primary care providers participated in separate focus groups facilitated by a research team member. We used a semi-structured interview guide with questions about PHRs, such as understanding, perceived value, desired features, and the perceptions of benefits of patient-generated data. Of note, we did not define PHR for participants until after they'd shared what they already understood about them. The data were then analyzed for main themes using a consensus process supported by NVivo data management software. So here's what our sample looked like. We had 9 patients of a mean age of 59. Most were women and of higher educational levels. 6 had college, 2 had some college education, and their self-reported technology use was always use or regular use. For the providers, there were 17, also mostly women. The professional categories were 8 general practitioners, 5 medical office assistants, 2 nurse practitioners, and 2 registered nurses. Their technology user category were primarily average to advanced, but 2 rated themselves as basic. Years in practice, were a mean of 12.
Thank you, Mindy. Lindsay, I'm one of the research teams. So what we found were that providers and patients had similar views and understanding of PHRs, but they had important differences based on the context, needs, and experiences. We had found two themes: the need for patient-oriented focus and the value of flexible and fluid communication. So for our first theme, patient-oriented focus, both patients and providers viewed the PHR as a patient-oriented tool for providing a comprehensive health illness story, giving patients agency and control, a repository for patient-generated data, providing greater accuracy, frequency, and currency of patient-reported information, and providers emphasized that the PHR could empower patients in decision-making and participation in their healthcare. So participants saw the PHR as a tool to address gaps and discontinuities in care by providing this comprehensive illness story. Providers highlighted that it could connect multiple providers and have up-to-date information, as well as addressing gaps in care for transient and first-time ED patients. Whereas patients saw this as the total health story. If there's missing pieces, it can all fall apart, so this needs to be comprehensive. They also saw it as a tool to avoid repeating their health history to multiple providers, which could trigger setbacks in their healthcare. Both patients and providers had very different orientations as to what patient-reported information would be. Providers had a very clinical perspective, wanting data on symptoms, blood pressure, and medication compliance, for example, whereas patients saw the data in the PHR much more health-oriented, wanting to track their food and exercise, and much more of that wellness perspective versus what they currently saw being held in the health record, which was all around sickness and illness. They also both talked a lot about the levels of that patients would have in control of the PHR. Providers saw patient control on sort of a spectrum, where some of them saw patients having only read access to the PHR, or having more of a collaborative PHR where both patients and providers were providing input and sharing information. And then finally, providers also talked about patients as the owner of the PHR, in comparison to patients who were unanimous that they should be in control of the personal health record. They wanted access, they wanted to determine what information was shared and with whom, and they wanted the ability to make changes and corrections to entries in the PHR to reflect their values. Both brought up concerns about what PHRs would have an impact on patients. The providers particularly were concerned about patient health literacy, and that if they lacked an understanding or a misinterpretation of information within the PHR, that could lead to patient anxiety. Both brought up concerns around how this information might negatively impact care with new providers. For example, if they'd had a negative relationship with a past provider, as well as concerns for patients who might be unable to use a PHR, those with impaired mental capacity, or those without computer access. So our second theme, the value of flexible and fluid communication. Both patients and providers talked a lot about features in the PHR that could allow for better connection between patients and providers. The features that providers highlighted were flexible appointment scheduling and follow-up, using video and secure texting to accommodate patients and providers. And they highlighted how this could create greater efficiencies, using these brief interactions to preserve in-office visits for those patients who really needed to be seen in person. The features patients described were really highlighting the importance of that bilateral communication with providers, wanting to be able to email and communicate back and forth. And those patients who had had experience with that really highlighted it as essential. They also saw it as a way to move information seamlessly between and amongst providers, particularly one patient describing how useful it would have been moving between provinces. So with that flexible and fluid communication, both of them wanted boundaries set. So providers were really focused on making sure that communication boundaries were set to preserve their workflow. They didn't want to be inundated with messages from patients, and they were really concerned about any extra time that it would be required for them to communicate with their patients outside of their normal workflow. However, we did have one NP in our sample who had experience using asynchronous communication, and she reflected that patients really weren't abusive of that. They weren't inundated with messages. And so, you know, providers really reflected on, because this hasn't been used a lot, there's a lot of unknowns as to what patient use is going to look like. The boundaries patients wanted to be set, in contrast to providers, was the nature of who they're sharing their information with. They wanted to be able to set limits and control, so that only certain providers had access to certain information, being able to wall off stuff for just their mental health providers, allowing them to have certain other providers to have access to other information, but really making sure that they were in control of that. So in conclusion, overall views of the PHR were positive. However, this divergence in their perspectives could influence the success of deploying a PHR. So particularly the orientations of what patient reported data was, the patient perspective of this whole health and wellness versus the provider perspective of clinical illness and sickness data. However, because of patients' interest in using the PHR as a tool for health promotion, it could kind of shift attention towards more of this prevention and promotion of healthy behaviors and away from that more clinical perspective. Differences also existed in the extent of who was in control and what control would look like of that PHR, from, you know, shared control between the patients and providers versus the patient has sole control or the provider has sole control. And there being a need to create boundaries within the PHR, whether that's for providers to set limits and control their workflow and their time, or for patients who has access to their information and who they're sharing it with. So just want to acknowledge the funding for this project was provided by the BC Support Unit. We wanted to thank all of the research team members who contributed to this project, and acknowledging the support and participation of our participants, as well as additional support that was provided by a collaborative EMR company, Input Health. So I think I've saved us enough time to take a couple of questions. Mindy?
Great. Yeah, I don't see any in the chat yet, but people, please feel free to write in questions.
That was a great presentation. Thank you, both Lindsay and Mindy and your team. While we wait, I'll just fill the gap. I have a quick question, or I mean, you addressed it in your presentation, but around the health and medical literacy, team-based care workflow. I'll turn the virtual mic over. Shelley, I think you or your team are up next.
That's not the title of our presentation, sorry.
Oh, okay. Oh, that was my mistake. Okay, I was going off order. I had a page break. Apologies.
No
so the next one is in fact yours, Bridging the Digital Divide, a scoping review to understand the barriers and facilitators. Youth face in accessing digital mental health technologies. Apologies for that. Go right ahead.
No worries. Melissa, you're on mute.
Hello, we're real this time. The joys of doing a virtual conference for the first time. I'm just going to share my screen once more, and then I will start our presentation. Sorry, everyone, for the technical glitches. Okay, here we go. Hope you can see my slide okay, and that you can hear and see me okay. So to begin, Shelley and myself, we're here to present Bridging the Digital Divide, a scoping review to understand the barriers and facilitators youth face in accessing digital mental health technology.
So we just want to acknowledge our funders, the BC Support Unit Patient Engagement Cluster and the Michael Smith Foundation for Health Research. And before we begin, we also want to honor the legacy of Sandra Dawson, who was a peer researcher and a mental health advocate. And our study is actually building on her digital literacy knowledge translation project.
So I'm going to go over the following for today's presentation, going to do an introduction, go over some of our scoping review objectives, and from there, the methods that went into that, the results, implications from it. I'm going to talk about some qualitative mixed method studies that we looked at. I'm going to talk about our qualitative study that we're currently running at this time, and highlight how youth have been involved throughout the whole process. So to begin, my name is Melissa. I will be conducting this presentation. I am a registered social worker. I'm a research assistant on this project, as well as a counselor. And my pronouns are she, her, and hers.
Hi, everyone. My name is Shelley. I'm an assistant professor at UBC Okanagan in the School of Social Work, and my pronouns are she, her, hers.
And we just want to acknowledge that we live and work in the unceded territory of the Syilx people here in the Okanagan. We're so grateful to live in a beautiful location where we can enjoy the land, the people, the mountains, the water, as it adds to our well-being and personal growth. As well, we're backed by an incredible team. So I just want to quickly introduce, we have Alicia, Nancy, and Rory as our youth ambassadors. We have Teresa, Michaela, Gervon, and Julia as our youth research assistants. And like I was saying before, how youth have been involved in this process. We also have Michaela here in the chat. So just want to shout out there. We have Dr. Sky Barbic. She's another co-lead of the study with Shelley. We have Curran. She's a research coordinator who supports us in so many ways. And again, I want to shout out that she's also here in the chat showing that support. So we're so grateful. We have Sarah, she's a research assistant as well, and one of the coaches who's helping to train the youth research assistants. And we have Charlotte, she is a librarian at UBC Vancouver who's helping with the scoping review. And I also wanted to provide some background as to where the ideas for this project came from and provide a landscape of what the current context is for youth mental health and digital technology. So for starters, 1 in 4 youth in Canada are affected by mental illness, and yet less than 20% of youth receive appropriate mental health treatment. So here's there's a bit of a gap between those who use services and those who are actually able to access them. But we know that youth are very tech savvy. They're the generation most connected to the internet. However, their voices seem to be missing in the decision-making process for interventions. A scoping review was done in 2018, and they found that youth opinions are often heard, but they're not part of the creative process in making the interventions. And importantly, we can't forget about the pandemic. COVID has led to a decrease in mental health in youth and an increase in the need for and leveraging technology as we're finding today, where we're all physically distancing and experiencing lockdown measures. So putting all these pieces together, it led to our research to improve and bridge the digital divide. And what I mean by digital divide is those who can access technology and those who can't. Specifically, we want to learn how can we improve mental health technology for youth, and how can we engage youth in the research process so their voices are part of that process. So this led us to our scoping review objectives, which is number 1, we needed to summarize the literature. We needed to know what was already out there for youth mental health and technology. And then number 2, we needed to understand what those barriers were for youth to access digital mental health technology, barriers to youth being engaged in that research process, and barriers to accessing digital technology itself. And then number 3, that was going to lead us to developing questions for our qualitative study once we gathered all that information. So our methods were, first we had to input search terms, which the image on the left is a word cloud of all the images we use. Examples included health, information, digital, mental health. And putting these search terms led to collecting over 10,000 articles. And so we screen these articles in Covenants. It's a bit faint, but the image on the right is a screenshot of what Covenants looks like. It's a program that was able to collect all those articles so we could screen them by their abstracts, by their titles. And that was a job done by myself, by Shelley, and by Sky. And what we were looking for, our inclusion exclusion criteria was, did the article involve youth? And importantly, did the article involve youth interacting with digital technology for mental health reasons? Another inclusion criteria, for example, was whether the article was in English or French. And then some examples, exclusion criteria were whether they did not include youth as participants, whether they did not include digital technology, or if they only looked at physical conditions of health, but not mental health conditions. And so we finished that in April or May, or March, April of this year, and we started it in November, which meant that during that time, the pandemic occurred, and we realized we had to update our search because of COVID-19 to see if anything had been published relating to the pandemic and mental health and digital technology. So that led to more articles being added, more screening for myself and Shelley and Sky, and then finally finishing that in about May or June of this year. And I just want to highlight that we also had youth ambassadors be part of that process. We would bounce ideas off them and ask them, do you think we're on the right track when it comes from that youth perspective? And they were so helpful in pointing out, like, hey, here are some definitions to terms that we're seeing in the articles. Or, hey, maybe you focus on the past 5 years, because they know that technology changes so quickly over time that it didn't make sense to focus on anything past 5 years. That was really helpful to have that youth perspective. So we realized that we got 335 articles that matched our criteria. So I'm just going to run through this due to our constraints of time, but our main themes were, number one was that articles were interested in the outcomes of an intervention. Number two, they were interested in hearing the needs for mental health technology from youth, which is great to see that they were gathering those opinions. Number three, they were interested in looking at how technology was used for help seeking, or how youth were using technology for help seeking. The top mental health concerns were, number one, just mental health as a whole. Number two, looking at least 2 mental health issues. So they may have studied anxiety and depression, for instance. And then the third top mental health concern was articles specifically studying just depression. The countries where articles were pulled from the most was number one, Australia. Number two, the US. Number three was a mix of different places, which is really interesting to see, and just speaking to the fact that technology can cross borders in the same way that we're all interacting from different locations. Number four was the UK, and Canada rounded out the top 5. When we looked at diversity, we noticed that there was only a limited amount of articles studying youth specifically from diverse populations. So we found that 7 articles were looking at youth who were street entrenched, 5 looking at individuals from the LGBTQIAS2+ community, 5 only looking at Indigenous youth populations, and only 2 looking specifically at cultural minority groups. As well, going back to that theme about youth being engaged in research, we found that 21% of studies engaged youth in the research process. So that was about 72 articles. Okay, so looking at all that, we realized there were some gaps. Number one was the diversity in youth. Number two was that youth weren't being engaged in research enough. Number three, that we needed to understand more about the facilitators and barriers to youth accessing technology so that we would know what the gaps were when we were developing our qualitative study. So this led to a greater review into those studies specific to those areas. We're still looking through the articles that are specific to the diverse populations, as well as the ones that had youth engaged in research. So for today, I'm just going to focus on the studies that we looked at for the qualitative and mixed method studies, because those were most needed and relevant to creating our qualitative study. So what did we find from all of those ones? There were 79 articles, 42 of those were qualitative studies, 35 were mixed methods. And the main themes from those articles was that researchers were interested in looking at the youth opinions on youth receiving and providing peer support for mental well-being. Number two was that youth were actually being part of the research process to co-design and create interventions, so that was fabulous to see. Number three was that they were asking youth about their preferences for features that they would like from different types of mental health technologies. Number four was they were asking youth about their experiences of being in the interventions, asking for their feedback. What did they think about the intervention? And number five was, again, that idea of help seeking, wanting to understand more about how youth were seeking help using mental health technologies. And we found some barriers and facilitators that the researchers had pulled to understand what was stopping and what was allowing youth to access digital mental health technology. So biggest barriers were the youth didn't feel safe online, whether they perceived that it wasn't safe or secure form of technology that prevented them from wanting to access it. Number two is if the mental health technology had a poor design or layout, it was difficult to read, it didn't make sense. So that was a big turnoff to wanting to engage with it. However, some facilitators, number one was whether it allowed youth to have that peer support and engagement. So whether they could interact on a forum or whether they could read reviews from other youth that was really important to have youth be a part of or to use that mental health technology. Number 2 is whether it had positive visuals and features. So was it visually attractive? Did it have things that were engaging? Were they able to personalize things? These were things that they really liked. As well, going back to that safety, did it provide the youth the ability to be anonymous if they wanted to? Did it look like they had moderators? So things that allowed youth to feel safe is what promoted them to use or made them feel safe enough to use that technology. And so reading all this, it gave us some ideas to create our qualitative study. We're calling this our digital divide study. And we are using interviews to capture the youth experience, using Zoom to be able to conduct the interviews. We're hoping to capture 30 to 45 participants ages between 12 to 24 across BC, Canada, because again, we want to hear about those youth voices, and interviews are a great way to get a lot of good information. And most exciting is that we're having our youth being interviewed by our youth research team. So we're, again, just promoting that connection between youth being engaged in research and making it a comfortable space for youth to talk to other youth. And so speaking of youth, here is our youth research team. And so the names are just provided at the top there, and the bottom is just a few of the things that they've been helping us. And first and foremost is the input and guidance they provided to share their youth perspective, giving us ideas of how we can make things more youth friendly, making sure that it's understandable from a youth perspective. So they helped us to actually create some of the interview questions, which is fabulous because there are some things not being a youth that I may not have understood or may have said things in a different way, for instance. They helped also create the promotional material to make it like visually attractive, which we know is a facilitator. They're also going to be leading the interviews, like I mentioned before, and they've been doing so much training to be able to achieve that. So again, providing that safety and security for other youth so they know that they're in good hands. And they're also writing about their experiences being part of the research process. So they're participating in a blog. It's not available just yet, but I can share a link to where other blog posts have been posted at this time. And then you can access that link at a later date to see more from the youth perspective. So thank you so much for listening. I know I just ran through that, but if you have any questions, please feel free to share in the chat because myself and Shelley would love to answer those. So thank you very much.
Thanks for that presentation. That was terrific. So again, I'll fill the gap just with a question while we're waiting for other questions to pop up. I'm curious, just one of those last slides. It was interesting that is it the youth ambassadors? Is that how you titled them? Were they all female? And I'm wondering what sort of input or what you would expect would be the difference with the input potentially from youth who are male and such.
Yes, so great question, Jason. We kind of have two groups of youth input. The first is our youth ambassadors who were basically there from the beginning of the project with our scoping review. And then our youth research assistants came online during the qualitative study portion. Now, gender is a tricky thing because it's a spectrum. So I'm just going to avoid putting those like dichotomous names on them. But we do have individuals who identify as they, we have individuals who identify as a she. And so I think just having that representation is absolutely important. And I hesitate to put those labels on the team itself. I don't want to speak on their behalf. But it is something that Shelley and I have been trying to be really cautious about, because we don't want to assume anything about gender, and we don't want to allow just our perspectives either to affect how we're understanding things. Or I think even as a team, we don't want to, I guess, negate any other perspectives. So that was kind of ambiguous, but did that kind of answer your question?
No, it did. And I think you phrased it a lot better than I did initially. It's how do you ensure you have appropriate or maybe representative representation? And so, no, that was great. Thank you. Mm-hmm. There's another question in the chat box there. I think the question from Sarah is, how did you help youths feel safe?
Yeah, great question, Sarah. So I think the biggest thing was our youth actually, the youth research assistants suggested that one of the things we do is talk about our gender pronouns. So again, we're not making any assumptions, but that they know that they can share their gender pronouns if they feel comfortable. We provide a land acknowledgement to, again, just provide that time that if they want to share anything about themselves and about their cultural background or connection. We also are training our youth, so we're practicing with them so that they can feel comfortable and confident approaching these interviews. We're going over scenarios of what could happen if a youth mentions something about a risk to themselves or others, so that the youth, we don't expect our youth research assistants to take that on, but we're just training them on how they can approach those situations from a non-judgmental space. So Shelley, is there anything else I'm missing that you think would be good to provide?
No, I think that's great. And I think we've learned so much from the young people about how to make an environment safe, and how to make an environment safe for the youth that we are going to interview. And so I feel like it's just been such a true co-develop. We really was like a partnership between, you know, the youth and it's just a really beautiful collaboration between all of our team members. And so we've learned so much along the way, and we continue to learn. And even in our recruitment, we want to try to make sure our recruitment is as inclusive as possible. And that was really guided by the young people. That's a great question though. I think, Selena, did you have a question?
I do. Thank you for the great work. I was curious if along your journey you determined which digital health tools or functionalities were really important to our youth with mental health concerns.
And do you mean, Selena, do you mean from the interviews we're gathering at this time, or do you mean in the research that we pulled beforehand in the literature?
In either.
In either.
You know, having pulled up either the literature and taking a look at youth using digital tools, I wonder if there's a great focus on the ability simply to communicate via text, or did they want the whole genre of capability?
Yeah, that's a great question, because there was some interesting differences that appeared for those who had thoughts on in-person, for instance, versus digital. So some enjoyed that the digital provided that anonymous space, versus some liked how, like getting in-person counseling, for instance, they enjoyed how there was a space away from home that they could talk to someone, that it was a comforting environment. But then again, we would hear from other youth that they didn't feel like they connected with that person because they were maybe of a different age group. So they preferred the digital space because they were able to engage with other youth who would be able to have, I guess, a similar experience, or at least a similar perspective. So it really kind of varied. And it kind of varied depending on the unique identity of the youth as well. So for instance, we just had a recent interview with someone who a big part of her identity was being an athlete, and she mentioned some stigma around not being able to communicate about mental health needs on the team. So the online space was really helpful so that she could use tools like privately, for instance. But in other areas, some people have like an online community that they feel very comfortable with sharing, that they have mental health tools that they use, that they have like resources that they can share. So it's a lot that we're learning, and I feel like I can't really provide you with one answer.
It's okay. Thank you. It's a great start.
Great. Thanks again to you both for that awesome presentation. We'll switch to the next and final presentation, entitled, this time correctly entitled, Integrating Patient-Centered Measurement into Team-Based Care Workflow.
Thank you. First, we'd like to acknowledge, respect, and honor the Tanaha, the Sinaiks, the Siniks, and the Shwepmek peoples in whose unceded traditional territory we work and live. We have several disclosures to report. Are you going to put up our slides, Selena or Marcy?
That would be me. And yes, Why can't I share them? Advanced sharing centering. Let me just see. I used to have.
I can't share either. It says like that the host.
Yeah, I used to be able to, and somehow that went away over the last 2 sessions.
Selena, just a minute. I'm gonna try to see if maybe I can assist.
Okay, thank you. You were so perfectly ready to go, Mindy, and I couldn't help.
I can sort of go over our disclosures. We have applied by.
It's okay. Pause for a second. I think we'll go ahead.
Okay. Could you try it now? Because you are, Selena, technically a co-host. Let's see if that works.
It says 1 participant can share at a time.
I've changed it to multiple, I believe. If it's not working, I can maybe make you the host and you just have to give it back to me when you're done. Let's try that.
That's dangerous.
It
Can
is.
you still hear me?
Selena, I'm
No,
going to
I'm
make
muted.
you Oh, no, we can hear you. I've made you the host, so now try it to see if it works. It should.
I am able to, Selena, if you want me to do it. Can you see mine?
Yay.
Okay, so just tell me when you want to shift and I'll.
All right. Thank you, Marcy.
Good, I was black up. All right, here we go.
Great. Okay, if you can move to the next slide, I'll go over our couple of disclosures. So we have funding by the BC Support Unit, Patient-Centered Measurement Methods Cluster. We have a relationship with a commercial interest that's Cambion, and that's the portal that we'll be using. And we have also gotten in-kind financial support from the BC Innovation Support Unit and the Kootenai Boundary Division of Family Practice. For the purpose of this talk and in our research, we only use the generic term portal. Okay, next slide. Our research is focused on how patient-generated data can be collected, used, and shared in supporting patients to become proactive partners in their care, and how these data can be integrated into system-level improvement in transforming the roles of patients, families, and caregivers and their healthcare providers. BC is transitioning to a patient-centered mode of team-based care, but for patients to become true partners in their care and for evaluating team-based care, patient-generated data is needed that can be integrated into regular care visits and decision-making. There are 2 kinds of patient-generated data that we're going to talk about. One are experience measures, or PREMs, and the other are outcome measures, or PROMs. The literature has described many challenges in deployment, collection, tracking, reviewing, and documenting patient-generated data. And care teams, including the care team we're working with, acknowledge being unable to effectively use and interpret these data due to lack of technical and organizational resources. Therefore, our overall aim is to develop new ways to incorporate patient-generated data into rural team-based clinical practice. Our objectives are to develop methods to integrate both the PROMs for supporting decisions with patients and their providers and PREMs for improving clinic performance. We'll be applying these methods to create and validate scenarios on how patient-generated data can be integrated and create a resource package that provides guidance on patient-generated data adoption methods. We're using a knowledge translation approach that actively involves patient partners, knowledge users, and researchers in all aspects of the study design. The direct knowledge users in this case are the KB Division of Family Practice and the clinical care teams. Patients and providers have been included as partners in the work, which we hope will enhance relevance and appreciation for how the learnings can be applied. And for this project, we've selected mental health as our focus area. There are multiple study methods used to identify adoption methods. We began with team mapping and workflow analysis, and that's what we'll be presenting today. There's going to be development and testing of portal resources. We use 2 patient partners and a University of Victoria undergraduate student to develop these resources. Patient feedback on patient-generated data collected through the portal will be obtained, And then we're going to analyze how the PROMs can be integrated into clinic workflow to support patients, and how the experience measures can be used to improve clinic performance. Patient partners have been involved throughout this process. From the grant proposal, we have monthly meetings as a team. Patients were used as researchers during the clinic mapping sessions and in the knowledge translation strategies. In the selection of the patient outcome measures that we use, such as the GAD-7, PHQ-9 to measure anxiety and depression, self-action plans, and we also have been involved in selecting the experience measures that hopefully will capture meaningful patient experience for team reflection. The portal itself looks like this. This can be a navigator. So when a patient logs in, this is what they see. The research team worked together to enter educational and community resource data that patients then can access. They're also alerted on their email about the presence of a questionnaire to complete, such as the GAD-7 or self-efficacy or experience measures. In addition, they can call up their own results from a patient health questionnaire and track that information, as you see in the right-hand side of the screen. I'll now turn it over to Selena to talk about the mapping and the workflow.
Sure. Thanks, Mindy. I'm going to trust that you can hear me.
I can.
Great, awesome. So building on our integrated knowledge translation approach, here I'll present some of our initial results related to the team mapping and to workflow. The researchers and knowledge users came together to map the team's roles and responsibilities. So the team being the social worker, the patient themselves. In this case on your screen, you'll see one of our simulated patients, Dan, and Dan's primary care registered nurse, their medical office assistant, the physician. And then we chose 2 simulated patients. So there was another one outside of Dan, both with mental health concerns. And the results were showing some of the actions of the teams, including that wider circle of care in the community, as you see in the outer approach, or the outer circle there. So again, the interviews were with the patient provider, patients, partners, as well as with the care providers to understand, using these 2 simulated patients with mental health concerns, how the team flows and roles with various measures coming in, what each of them do, how they communicate with each other, what actions they take, and what resources they have to take those actions. This slide, while it's full of text, simply just want to, thanks Marcy, wanted to illustrate the gaps that we received with our team mapping sessions, quite detailed understanding of the various gaps that were identified during these sessions. And so we included here just simply to represent that and to illustrate how many there were, some of which we will have an opportunity to solve perhaps within our study. Another piece of our results and initial work was around the team of researchers and knowledge users working to identify an initial workflow for the team, which will be used in the next phase of our study and adjusted as we learn together. So in this particular initial workflow diagram, we explored the different tools that would be used. You'll see that rolling across one of the lower roles with an EMR versus the portal, back to an EMR and portal use again, etc. And then the various roles from social worker up to medical office assistant, etc., in terms of what actions they might take to both deploy or to complete or to track and triage or to document the various measures that we were going to incorporate, like Mindy had mentioned, the PHQ-9 or GAD-7, some of those patient reported outcome measures, experience measures, and some of those self-action plans, etc. So there are, this sort of carries right on through to the clinic visits, and obviously circles back to whether we need to schedule another clinic visit, etc. We've also included an opportunity in the workflow to deal with quality improvement. And that again will be a portion of our next phase of our study. So again, this actual workflow was initiated with the conversations between patient partners and the clinical teams and researchers to understand the current state and the state we'll walk into our next phase with, and iterate as we learn an improved workflow or a changed workflow as appropriate to best integrate patient-generated data. In terms of results summaries, for patients with mental health, stigma is a concern, and equitable access to technology, in particular in rural communities, is problematic. We learned that there's limited knowledge about team-based care. With the use of digital patient-provider tools comes challenges in communications around particular communications and expectations. From a clinical team workflow perspective, we identified the inadequate electronic support for the tracking and integrating of patient-generated data, and resources to engage quality improvement, certainly approach around that. In conclusion, both the perceived value and the integration of patient-generated data into clinical practice remains challenging. Our integrated knowledge translation approach appears beneficial methodology in its initial work because our knowledge users, for example, very specifically the patients and care providers in this case, their needs related to the collection and integration and use of that data are being applied repeatedly, really bridging that knowledge to action gap. While few actionable outputs exist, one that we are certainly using to guide our work, and you'll see the link there on the screen, is an online toolkit for patient-reported outcome measures. We are certainly grateful for that, and really the impact of our work will be to add to that, and our overall aim to add this actionable output and demonstrate how we can collect, integrate, and use patient-generated data to enhance performance of teams and support the patients as active partners in care. In terms of next steps, we really are at the study recruitment phase, having done that in this initial phase, and a small sample of patients with mental concerns is proposed or purposed, and to really use the portal and generate data for integration and use in care. Our integrated knowledge translation approach will continue throughout the study and certainly supporting all aspects, and like the application of our adoption methods to create and validate some scenarios, as well as the interviews will offer that rich description and certainly aid to that final development of a resource package suitable for our knowledge translation going forward. And on screen will be the references. I believe you will get copies of those should you wish to take a look at those. Much gratitude to our large team. I know that on your slides on the screen, because you're not using my slides, they were slightly updated, so the order is slightly different, but that's okay. Gratitude to the team, and certainly finally, thank you.
Great, thank you, Mindy and Selena. That was terrific. We'll have opportunity to take some questions. We're a little bit behind, but I think we're going to be okay. 1 to 2 questions should work just fine. While we're waiting for some questions to come in, I'll just mention that the poster session will begin promptly at 11:30. The links are available on the website, the conference website, and that the plenary sessions will resume at 1 p.m. So I'll turn it over for any questions. All right, well, if no questions, Mindy, Selena, thank you again. I could turn it over to you if you have any final comments, but otherwise we can conclude.
No, I just appreciate this conference and being able to present our work. I found it to be a fascinating journey in terms of trying to figure out ways of making patients more active participants in their care. So I applaud these efforts.
Mm-hmm. And I also want to acknowledge the concept of equitable access to even the internet access. Check out where Mindy is in her car. She had to drive to town in order to ensure that she has access to this. So rural access is already a big piece. So champion Mindy, well done. Thank you.
Well said. And thank you again to all the presenters for this session, digital engagement, and for everyone for your questions and for your participation. So we'll conclude, and there's lots more for the Putting Patients First conference throughout the morning, what's left of the morning, and through the afternoon. So thank you, and take care.
Bye, everybody.